TV, get ready. Five, 4, 3, 2, 1. Good afternoon and welcome, distinguished colleagues and doctors. Today is Wednesday, September 21st. It's now 3 p.m. This is the Rhode Island House of Representatives COVID-19 Task Force, and we are meeting today with some updates. But for some preliminary stuff that I have to take care of before we get started, and for the people who are watching, I will explain who was on this committee and why this committee was established. Under Speaker Joseph Sakachi, he announced that this House committee will form a task force for the COVID-19 distribution throughout the state. On this committee, we have Representative Karen Elzate from District 60, Pawtucket, Representative Michael Chippendale from District 40, Foster, Gloucester, Coventry, Representative Kathleen Fogarty from District 35, South Kingstown, Representative Giraldo, District 56 from Central Falls, Representative Hagan McAtee from District 33, South Kingstown, Narragansett, Representative Magoa from District 71, Portsmouth, Tiverton, and Little Compton, Representative Mary Duffy Messier, District 62 from Pawtucket, Representative Noah Ray from District 25, Coventry, West Warwick, Representative Place from District 47, Burrillville, and Gloucester, and myself, Representative Hull, from District 6, Providence, North Providence. I thank everyone for being here. We will be thorough as we most possibly can today to give information to the public who are asking for maybe some tough questions that need to be answered this afternoon. We will be polite, we will be understanding, but most importantly, we have an obligation to the people that we serve. So please bear with us with the questions that we'll have for you as we begin. At this time, I call on my clerk to read the agenda, please, and we will start with the agenda right shortly after that.
Certainly.
Ms.
Thank you.
Lanny.
Thank you, Chair Hull. Good afternoon, representatives and invited guests. Our agenda this afternoon is to hear from Dr. Nicole Alexander Scott, who is the director of the Rhode Island Department of Health, and Dr. Philip A. Chan, who is a consultant medical director with the Rhode Island Department of Health and associate professor in the Department of Medicine at Brown University. We have 4 agenda items that we'll be hearing from our 2 physicians this afternoon, and that is a Delta variant update, the data that has been secured by the Department of Health, as well as what is the school vaccine uptake and distribution, the mask mandate that is in place for healthcare workers, and also the booster vaccine process, and certainly any updated data on that item. Dr. Michael Fine will follow, and he is the Chief Health Strategist for the City of Central Falls and Pawtucket in Rhode Island, as well as the Medical Director of Beat COVID-19, and he will provide perspective and update from his thoughts. There will be no public testimony accepted at this meeting, and so, Chair Hull, back to you.
Thank you very much, Lynn. And for those of people who are watching, our emails are available if you want to email us, and my phone works, so if I can get an email if you wish to send an email, and if you need a question answered, that's fine also. With that said, I don't know who's going to go first over there. Dr. Scott, welcome, and you have the floor.
Thank you, Chairman. It is an honor to be here this afternoon. Great to see the committee and everyone who is watching, and of course, Lynn. Thank you very much also to the team of people, not only who helped us in preparing this, but who was also actually out there doing the work on the front lines it's certainly on their behalf that I'm honored to be here today and share where we are with COVID-19 and our vaccine and overall update. So I'm honored to have Dr. Phil Chan, who's one of our esteemed medical directors at the health department and a colleague of mine for many years and with infectious diseases as well, who's going to get us started with our data update and vaccination campaign overview, and then I will be able to go in further with what we are doing with our vaccination campaign rollout overall.
Great. Thank you, Director, and good afternoon, everyone. It's a pleasure to be here in person. I'm going to start off just talking about some trends and update on the Delta virus and where we are with cases. So you can see here on slide 4, this is a summary of our very tough winter. As everyone knows, we had a very high number of cases, hospitalizations, and deaths. It was a very tough winter, 2020, 2021 here. In the summer, starting in June and July, again, slide 4, you can see that we bottomed out. And so we were beginning the summer started well. But unfortunately now, we've gone back to another peak. And you can see the significant increase across both cases, hospitalizations, as well as deaths now, slight uptick through July and August. Next slide, please. What is to blame for this? The Delta variant is to blame, and I think that there's really no question about that, and the data supports that both here in the state of Rhode Island as well as across really the world and the United States. If you look at the orange now, the orange is the Delta variant. And I guess what's really striking about this graph here is that the red line, if you back up during the winter, the red line is the Alpha variant, B.1.1.7. That was a variant that was first identified in the UK. It was 50% more infectious than the original strain of COVID. And the problem is the Delta variant is 50% more infectious than the Alpha strain. So you now have a variant, the Delta variant, which is 2 times more infectious, and that's why we've really seen it spread like wildfire throughout not just Rhode Island, but across the United States and the world. This was the variant that was first identified in India. For those of you that have followed COVID on a worldwide stage, India was essentially overwhelmed with their hospital systems. You couldn't get oxygen, you couldn't get a hospital bed, et cetera. So what's blunted this peak in the country, including Rhode Island, has really been vaccinations, and that's obviously the key, and we'll talk a little bit more about that. But you can see here the Delta variant is the real thing, and it really had the potential to devastate everything, both in terms of deaths, hospitalizations, et cetera. Next slide, please. So let's talk a little bit about what our models have shown us. And I want to preempt these slides by first saying that models are just that. These models change every day. They're based on the best available data, and they're just that. They're models. So we need to take these with a grain of salt. These are where the models stand currently. And I want to say first off is that we've been following these models. We basically get daily, weekly updates of these models. And looking at these models over the last few weeks, these look a lot better than they were. So these models initially were projected to be much worse. We were really concerned about hospital capacity. These models showed that we were going to overwhelm hospital capacity. It's why we've worked to set back up the alternate care sites. So we believe that we're in a much better place. But I just want to, again, caution people as you look at these numbers that they are based on some assumptions and they're based on where we are. So if you look at these slides, the first slide here, if you want to go back, yep, we see the number of cases, total cases in the state of Rhode Island, which represents both people that have been diagnosed, so those are the actual people that we see, as well as people that are infected and have not been tested. And so as we look at the number of people that test positive on any given day, that of course is a minority of the people that are overall infected in the state. And we estimate, you can see here, that for any given day is that there's about upwards of a few hundred cases per day here in the state of Rhode Island. You can see on the second panel here, this is prevalence. So this is the number of people that are infected on any given day in the state of Rhode Island. And that means not just diagnosed, but people that have been diagnosed for a few days and that are still somewhere within their course of illness. And you can see here that we still have a significant burden of people living with COVID here in the state of Rhode Island, certainly around 6,000 or 7,000 at the current time. Now, the good news is that we have seen a little bit of a leveling off over the last few weeks. If you look at sort of where we are and where we've been the last few weeks, the slope does appear to be decreasing slightly. We have talked with our modeling team and our data people. We are seeing and we are concerned about a little bit of a bump due to opening of schools, so both K through 12 as well as colleges and universities. As some of you may have read in the paper, there was a slight bump at some of the local universities who identified a number of asymptomatic cases, and then there's Labor Day as well. So we are seeing in the last few days potentially a slight bump up in cases. So we're not out of the woods yet. The other thing I'd like to mention is that based on these models, that some of the tactics, some of the strategies that we have implemented, such as masking, such as other approaches, have really, again, blunted the peaks. So the modeling of these peaks, of these cases, were much higher if we hadn't implemented things like masks, access to testing, et cetera. So that's just another point to make. Next slide, please. Please.
If you could remember that you have 2 slides up there. For the people that are watching, please explain to them the first chart versus the second chart so that they're just not looking at a chart and not understanding where you're at. We can see you, but they may not be understanding what chart you're at or you're on. So just to be a little bit more clear
Sure.
to the people who are watching.
For sure.
Thanks.
So just again to state, on slide 6, if we want to pull that up, on the left-hand panel are the total number of people diagnosed per day in the state of Rhode Island. And so this is higher than what you may see on our website in terms of positive tests. This takes into account the total number of people that may not even been tested. And then on the right panel are the number of people who are living with COVID at any given time in the state of Rhode Island. So that includes people that may have been diagnosed 5 days ago that still have COVID, et cetera. So you can see that we still have a burden of disease at any one time in the state of in excess of 5,000 or 6,000 at the current time. Next slide, please. One thing that we've been concerned about is hospital admissions. This has been a key point, obviously. Many of you have probably seen stories in the media about, in other places, not Rhode Island, about people that have died, frankly, because they couldn't have gotten access to medical care, not just for COVID, but things like heart attacks and strokes. If our hospital system becomes overwhelmed, the mortality increases because people can't get access to basic medical care that they normally would. So we've been following hospital admissions very carefully. You can see here on the left panel on slide 7 that initially back in August that we were really having an exponential increase in hospital admissions. This was incredibly concerning as well, and we talked with the hospital leadership, and it was pointing to the fact that the hospitals were going to be overwhelmed this month. The good news is that hospital admissions have leveled off a little bit. You can see here, but we are still seeing depending on the day that you look at, a significant number of hospital admissions. So it does look like it's plateaued a little bit. Again, though, we are worried about a slight bump in cases that we have seen as a result of Labor Day, as a result of K through 12 college and university opening. On the right panel here on the slide, you see hospital census. So this is the number of people admitted to the hospital, in the hospital at any one time due to COVID-19. And you can see here part of this is dependent on what the average hospital stay is, and you can see here it's modeled to be around 7 days, and you can see here that we again are somewhere it's decreased slightly. We're still in a little bit of a plateau period, and it's early to tell. Again, these models do tend to change, so let's take them with a grain of salt. Next slide, please. This is also a really important slide relating to the number of deaths due to COVID here in the state. You can see in June and early July, we had actually hit a low point, which is good, between 0 and 1 deaths per day. You can see that that has ticked upwards, certainly during late August here, early September. We had a max of 6 deaths on a given day due to COVID, but it also appears to have leveled off. The one thing I will make a note about this is that deaths, of course, do lag a couple weeks behind hospitalizations, which also lag behind diagnoses. So we have learned to also take some of these trends, and they need a little bit of time in order to tell the true story, the trends, et cetera. Next slide, please. Our vaccine campaign. So let's talk a little bit about where we are. So very exciting this week. I'll start with the exciting news, is that Pfizer did announce, certainly for 5 to 11-year-olds, present some data, release some data to the public, which is being reviewed as we speak by the FDA. But the good news is that we do anticipate authorization of the Pfizer vaccine, hopefully this month for 5 to 11-year-olds. So that's something that we are preparing for. Perhaps the director can talk a little bit more about that in a second. But where we are now, I think as most people know, is that we do have a fully authorized vaccine for age 16 and older, the Pfizer vaccine, which was fully approved last month. We also have that same vaccine that is authorized by the FDA for 12 to 16-year-olds. We have the Moderna vaccine, which is authorized for 18 and older, and they've submitted for full approval, and the FDA is evaluating that now. And then we have the Johnson & Johnson vaccine, which is also under EUA for age 18 or older. We know that all three vaccines are incredibly protective. If you look through the scientific literature, there's like an article a day now, probably a couple articles a week, a couple big articles a week, that have looked at the effectiveness of the vaccine in real-world clinical settings, healthcare workers, first responders, et cetera, that demonstrate how effective this vaccine is, not just in terms of efficacy, but also safety. These vaccines are really incredibly safe. So it's something to be reassured about. Again, I have a 10 and a 14-year-old. My 14-year-old has got the vaccine. She got the Pfizer vaccine when it was first authorized for those above 12. And my 10-year-old will get the vaccine as well when it's authorized for the age group. And believe me, obviously I wouldn't do anything to put my kids in jeopardy. I believe I've reviewed the safety data, the efficacy data. It works, it's safe. And I just want people to be reassured about that. The other good news I just want to highlight is that Rhode Island does maintain one of the highest vaccine administration rates in the country. And this is really a tribute to the entire state of government, Department of Health for sure, but also the governor's team and all the partners that we've had, all of our clinical partners in getting the vaccine out. We really have, I believe it's ranked number 5 in the entire country in terms of vaccine rates. So we've done a good job overall. Also tribute to the people out there just getting vaccinated and being willing to do that. Next slide, please, slide 11. So where are we now? So at the current time, as of yesterday, 66.6% of Rhode Islanders are fully vaccinated against COVID, and that includes about 78% of Rhode Islanders 18 and plus who are fully vaccinated. 74.2% of Rhode Islanders are partially vaccinated. You can see here that's 86% plus of 18 plus year-old of Rhode Islanders. And this also aligns with the federal COVID plan. And many of you probably watched the Biden speech the other day. But vaccinating the unvaccinated has really been a key priority, and we're really pushing that. The vaccine is the way that we're going to end the pandemic. It's really effective. It's safe. We really need to push the vaccine as much as we can. And this also goes along with booster doses, so this is also a moving target. One of the things about the science, as we've all seen with the pandemic, is that the science is evolving. It's evolving, frankly, at an incredibly rapid pace from week to week. We know that booster shots are authorized for people that are immunocompromised, and we're waiting on the FDA and the CDC to make an announcement about their thoughts about booster doses for example, older adults, healthcare workers, et cetera. So we're still waiting for some guidance from the FDA, the CDC on that. And with that, I'll turn it over to the director to talk about our current vaccine campaign efforts. Thank you.
Excellent. Thank you, Dr. Chan. We wanted to be able to highlight that with boosters, we have a full comprehensive program that our team is prepared with across operations, vaccine administrator readiness, supporting all of the functions that are needed, and any of the key considerations. So we'd be happy to go through any of that detail. We're staying very close to our federal partners as it unfolds. So I want to be able to dig in a little bit further on how we have approached our campaign overall and where we are in that full campaign strategy. We look back on our previous times together. We had phase 1 of our vaccination campaign that came under a lot of heat because of the approach to really be targeted, to really focus on those that are most vulnerable and at highest risk. And we all saw together being pleased with the outcomes of having the greatest drop in our hospitalizations and fatalities in the quickest amount of time. We're among the states that did that, so it was worth the approach. Our phase 2 then went into vaccinating not only our highest risk and taking into account the equity perspective, but then also built in phase 3, which was getting out as many vaccines as possible as quickly as we can. And knowing that that's a key piece it's since that time that we have been at the front of the line in terms of vaccination rates. Where we are with phase 4 is in addition to really getting into the level of granularity and meeting people where they are, we are also now focusing on those policy solutions, which is a critical public health tool that has made it so that we have been leaders in immunization since the very beginning for a couple of decades. And so really applying some of the policies in place to help shift our culture and work it into a normal approach for getting vaccinated, because that is what's going to be key to getting us through this pandemic and allowing our schools and our economy to function as effectively as possible. So digging in on that phase 4 and looking at the key drivers for increasing demand, particularly looking at the policy approach, we're certainly going to be ready with the advancement since the full FDA approval in terms of supporting policies that require vaccination. Similarly, it is effective for getting back to school, and what was just shared for those younger than 12 becoming eligible for vaccines. We'll also be able to build that into our school entry approach that has helped make Rhode Island so successful. And then what we are also engaging in is our healthcare worker requirement and businesses outreach. We really want to help our stakeholders have the tools that they need to be effective in making the places safe, making people feel comfortable and confident to go out into the public, to engage in our commerce and our businesses, to go to our healthcare facilities, receive the services that are necessary, and do it in an environment where they know they will be kept safe. So that's a key part, and our boosters, as I mentioned, will help support that. I know the biggest policy that people are most interested in and that we see as being extremely effective in setting the stage is our healthcare worker vaccination requirements. So I want to talk a little bit about that and what our enforcement strategy is. Similar to what our approach is with vaccination-related policies overall, we have two major goals that are constantly in the forefront. We want to ensure safe healthcare settings protected against COVID so that there are as many people vaccinated as possible working in those healthcare settings, and patients and families can be confident that they are not going to be exposed to COVID by going into those healthcare settings and can continue to engage in receiving the care and services that they need while sustaining high quality care across a stable healthcare system. So we want to make sure the environment is as safe as possible and make sure we do it in a way that maintains the high quality care and stability of our healthcare system to be able to do that. We always want to make sure, as you've heard from Dr. Chan, and just understanding how the Rhode Island Department of Health, how we move in doing our work, it is always based on the data and the science. And so we've included examples of studies that show how effective COVID-19 vaccination is at preventing hospitalizations. The new information, we're also learning about preventing transmission of the virus, and even for those who have already been infected, being able to help reduce reinfection is an advantage that can occur with the vaccination. We also wanted to emphasize how we are in the lead in terms of states throughout the nation. All of my public health counterparts and colleagues are absolutely recognizing the same phase, the importance of advancing this critical public health tool within the realm of policies and requirements and helping to shift the culture. So you see the number of states that have incorporated healthcare worker vaccination requirements for the various facilities, and all requiring vaccination within the same time frame that we are in now in September and into October. So wanted to provide some quantitative data as a starting point for where we are. We're still just in advance of our October 1st timeframe, and we want to make sure that we are well positioned to achieve the two goals that I shared: making our healthcare environments as safe as possible with as many people vaccinated against COVID, providing care for our most vulnerable patients, and ensuring high quality care with a stable healthcare system. So what's key about this slide is understanding how well positioned we are to start. On September 2nd, we did an assessment of what our vaccination rates were across all of our 415 healthcare facilities, and at that point saw that 76.6% were already vaccinated against COVID-19. We repeated that assessment but from September 2nd to September 13th and saw that it's working. Where we're going is working, and implementing the enforcement of this October 1st is having the impact that we need, because there was a 10-point increase from September 2nd to September 13th in terms of the healthcare workers who have been vaccinated. It's now at, as of September 13th, 86.6%. So we want to continue to drive it to full compliance by the time of October 1st, but want to also acknowledge and celebrate all of the facilities and healthcare workers who are out there recognizing the importance of our responsibility in this field to ensure that patients are as safe as possible. One of the things that we did with a part of this assessment also is get more qualitative information when we dug in deeper on those facilities who were less than 80% vaccinated. On September 2nd, that number was 69 facilities, and on September 13th, it had decreased to 41 facilities that were less than 80% vaccinated.
Excuse me, Doctor. I was going to wait for questions until after you made your presentation, but something just came up. Representative Place.
Thank you, Chairman. Director, so based on the numbers you're showing us, the total percentage, I just wanted to make sure that I'm making sure this is totally accurate. I've been told by people in the field that if they're not vaccinated, some of these people have left their jobs. So the total number of healthcare workers at a particular point in time, I believe 9/1, 9/2 timeframe, was the first round of layoffs or firings that took place because of the mandate. So I'm wondering, have you accounted, is the numbers we're showing, so the vaccine rate as of 9/13, are those accounting for employees that have already been fired because of the mandate, or are you just assuming the number of employees have remained the same as of the first date in which you present the numbers for?
We are basing the results on what the healthcare facilities have informed us of, so they should have been telling us on September 2nd what their number vaccinated is, based on what their denominator is at that time, and then also on September 13th, they should have told us that number. I do want to clarify that no one has been asked to be fired at this point in order for it to come into compliance with our healthcare worker requirement. October 1st is the date. People have up till September 30th even to get the J&J vaccine and be able to still qualify. So that number should be very small unless employers had other reasons to let someone go.
And we will hold off on questions until after your presentation.
Thank you, sir.
Thank you.
So the qualitative data, when we assessed among those facilities that were less than 80% vaccinated on September 2nd, what additional information we could entail. 54 responded to our inquiries, and we saw that 8 of them reported some form of impact to operations that they are concerned about. And fully, that is 2% of all those who have responded to us. So being able to see how small the number is that there is concern about operational concerns is important, first and foremost. And then second, that also helped inform what our enforcement approach is. We are requiring that there is 100% compliance by 10/1, and we're very encouraged that this qualitative data relayed the majority of healthcare facilities noted that they do plan to achieve the 100% compliance by October 1. We also were able to take into account the additional feedback when we asked what any main concerns were, what were they doing to close the gaps, and how were they going to ensure the high quality of care that is the key to our goal with this process, and then take that information to inform what I'm going to describe next, which is our enforcement strategy. So enforcement implementation begins October 1st and is intended to have all facilities be compliant with the regulations. That is our full expectation come October 1st. Similar to how we approach all of our enforcement as a regulatory body, we are going to take a deliberate approach and a tailored one in how we are implementing our enforcement strategy. To mitigate risk to patient outcomes, that is to ensure that we maintain the stability of our healthcare system as we go through this process, our second goal, we are requiring any facility that is concerned about being non-compliant, which is a small number based on what they had reported, to be accountable to a corrective action plan that the Rhode Island Department of Health will enforce. Our approach with doing this is to ensure that if patient outcomes are at risk because critical staff are non-compliant, facilities will have this opportunity to maintain the stability of their healthcare system and submit a corrective action plan so that they come into full compliance within 30 days. I will be clear, this is only limited to a certain number of facilities and will require the type of close work with us as a part of the enforcement strategy. And I will be clear that every healthcare system will be accountable to the public. We are approaching this in a way such that Rhode Islanders will know which facilities are compliant come October 1st so that they are able to make the appropriate healthcare decisions they need to make for themselves and their families in keeping them safe. So that's an important component of this. So October 1st, we will be requiring an attestation from facilities and licensees where they can attest to being compliant, fully compliant by October 1st. And we will publish that so that everyone will know transparently all of those compliant facilities that are present throughout Rhode Island. The non-compliant facilities and licensees will be required to articulate a corrective action plan that requires them to come into full compliance within 30 days. Examples of what will be required as a part of that corrective action plan that would also be due October 1st includes the facility's plan with the timelines within those 30 days within which they will ensure that all healthcare workers will become fully vaccinated by that time frame. Demonstrate that any unvaccinated staff who are still working are only doing so because they are essential to the facility's operation and maintaining safety and patients' outcomes not being negatively impacted. They will also need to specify the additional infection prevention measures that the facility will be taking regarding any unvaccinated staff who are being required to get into full compliance during this time frame, and outline the facility's procedure to ensure that any new hires who are brought on are already fully vaccinated against COVID-19 for going forward. That will be a prerequisite for being hired. And then within this corrective action plan timeframe of the 30 days, we will be escalating any enforcement as we see fit that taps into all of the elements across our regulatory authority to ensure the accountability to the corrective action plan and achievement of full compliance as soon as possible and no later than that 30-day time frame. For next steps with that approach, so that everyone's aware, we have been engaging with stakeholders such as yourselves as well, trade organizations, and the public to make clear this enforcement strategy starting the week of September 13th. We will also be disseminating the corrective action plan template to facilities next week, and then activating the website for communicating facilities that are compliant so that we can enable all Rhode Islanders to make fully informed decisions on where they receive their care. And come October 1st, enforcement will be fully activated. So I will finish with a few quick updates on K through 12 and our outreach to businesses. That's been critical to our overall policy approach. We know that low COVID-19 transmission rates actually exist in the school setting. It is rare, less common for transmission actually to occur within schools. And we learned that by seeing from September of 2020 to July of 2021, only 5.4% of positive cases among Rhode Island's pre-K through 12 students and staff were reported as documented school-based only exposures, only 5%. All the rest are related to community exposures, which is why high transmission rates, as you'll hear more about also from our next speaker, Dr. Fine, are critical pieces to being able to control the spread that's in place. One of the slides that's very educational to equip the public with, particularly parents and families in our school community, is the understanding of compliance with the prevention strategies that we know work. That's the key message that we can share. What we learned last year is what's going to help us to get through the rest of this time. Vaccination, indoor masking, ventilation, active testing, those are prevention strategies that work. And we want to make sure that families, school communities, all can work together to make sure in every district that we are fully implementing, strictly enforcing, effectively carrying out those prevention strategies. This graphic shows it's not just about having the prevention strategies and knowing them on a policy, but it's also following through and implementing them as effectively as possible. The red shows what happens with new cases per day among our unvaccinated as of today. Thankfully, we'll hopefully get updated information on that. But among children 5 to 11, when you have no prevention strategies in place, during this peak time, we could be experiencing thousands and thousands of cases per day. And that's whether we document it or not, because oftentimes children are asymptomatic or don't go get tested. But showing how prevalent the Delta strain is, particularly when it's in a population that is unvaccinated, can lead to thousands of cases per day. If we have the prevention strategies, which is the yellow line, but don't implement them effectively, consistently, With the full compliance that we know is needed, we can see some decrease in those cases, but still be dealing with a few thousand. It's really achieving what we have been and can do on the green line going across. We know what the strategies are. Families, school communities, businesses, everyone working together to implement them effectively and keeping that going consistently is what's going to make it so that we don't have the increase in cases. This is just a few hundred cases per day. That is absolutely doable. That's the key message to talk about with masks. With public schools, we issued the indoor masking policy. That's one of our critical prevention strategies. It's vaccination plus these steps in order to have that bottom green line that's in place. So our community working together to ensure everyone is doing this effectively in our schools is what's going to make the difference. We know about the science behind masking. We know that it works. It blocks the release of exhaled virus. We know that mask wearing does not cause significant adverse health effects for wearers. Our children have been able to do it amazingly. It saves lives. It makes a difference. It's an easy, doable tool. That's key to public health. What's a tool you can use? A seatbelt, indoor masks work to be able to help keep our line the way we need to, that green line going across with as few cases as possible. Here are the successful prevention strategies that we knew worked in 2021. We're continuing it again. We distributed 6,000 plus HEPA filters to schools to make sure they had ventilation going. We know masking is critical indoors. Our testing program is leading in the nation. That continues to need to be accessed, and our EPI operational team does amazing, amazing work with case investigation and contact tracing that's critical to follow. So really understanding that schools, the public, all of us can work together to ensure that we are complying with these doable prevention strategies. That's going to be the way to keep our schools open successfully, to keep our economy thriving, give people the confidence to go out to businesses and participate in the economy. It's ensuring vaccination, distancing, masking, ventilation, testing, all of the steps that we need to do. And that's what we've shared with our businesses. There are 4 key tools you can do. Being able to do that allows you to, with confidence, tell your consumers, tell your employees, this is a safe place to come to. Let it be known. You can still come out safely doing this in COVID, even with the high transmission rates that are there. If businesses work on getting vaccination policies that require their employees to be vaccinated, even consider requiring vaccination to enter, you can say that's a safe place. Having testing programs available for your employees, for customers, we have that as a resource that's there. We want to support businesses in being able to do the different types of ventilation approaches that work. Many are already doing it. Let's make sure every business has that opportunity. And indoor masking is such an easy tool to be able to put into place. Doing all 4 of these give businesses the top notch in being able to say, with confidence, here's a place you can come to and feel safe and shop and eat and do all the things that we want to encourage throughout Rhode Island. We know we can get through this together. We have the tools, and it's our focus based on data and science to make sure you have it and know vaccination, indoor masking, testing regularly, and ventilation. Those are going to be the keys to get us through this safely. Thank you.
Thank you, Dr. Scott. I just wanted to go back to Dr. Chan for some clarification on the data and the vaccine. Could you please state again for the record how safe the vaccine is?
For the record,
yeah.
the vaccines are incredibly, incredibly safe. There are some rare adverse events that have popped up. They've been recognized by the FDA. They're very rare. The vaccines are safe and effective.
Thank you. With that, I'll open up for some questions before we move on. Representative Messier.
Good afternoon. I just have a question about those people that are in the hospital now with the COVID. Are they all unvaccinated people? Or, 'cause I think people are confused about that.
What we know for sure is the vaccines are not only safe, but they are extremely effective, keeping people alive and keeping people out of the hospital. Those who are in the hospital now have a 3 to 5 times higher chance of being unvaccinated. So the vaccine does work extremely well in making it so that the majority of the people over time that are actually hospitalized are people who have not gotten vaccinated yet and are putting themselves at a significantly higher risk of being hospitalized or, unfortunately, of dying. I often look at it as if you have a loved one and you want them to stay alive and you would give them any tool you can to help make that be possible, what we've seen from the data is there's an over 90% chance, if you make sure that they are vaccinated, staying alive, even if they are infected with COVID-19, is significantly higher. The same for vaccination. And really making sure that your loved ones have that kind of tool is what we want to get the message out from a public health standpoint.
And so those people who are vaccinated, and you said it's highly effective, what are the percentages that they would still pass it to someone else?
So we do know that the vaccine protects highly against hospitalization and severe disease. There is still a small chance that someone can be infected and potentially pass it along. We don't know the exact numbers there. It varies by study. It does appear, though, that high 80+%, the vaccine is going to protect you just against being infected, and then high 90s in terms of preventing hospitalizations and deaths. I will share one quick story, though. I had a patient last week who's immunocompromised. She's in her late 20s, immunocompromised. She's an autoimmune disease. She takes some immunosuppressives. She'd gotten 3 doses of the Pfizer vaccine. So she had gotten the regular dosing regimen as well as boosters, and she still got COVID. Now, luckily, she was able to get monoclonal antibodies, but this just points really to the need that the rest of us need to get vaccinated, is to protect the subset of people that are immunocompromised, even who are getting vaccinated. And the vaccine is a little bit less likely to provide full protection in those that are immunocompromised, which is why they need a booster shot. But even then, they can still potentially get COVID. So this just really speaks to the fact that for those of us that have normal, healthy immune systems, all of us need to get vaccinated to do our part.
Representative McGaul.
Thank you so much for being here and for your presentation. I really appreciate it. I was hoping you could talk a little bit about the relationship between low vaccination rates and the development of new variants.
I didn't catch the last part, low vaccination rates.
And the development of new potential variants.
New variants.
Going forward.
This is the biggest unknown, in my opinion, the pandemic and where we're going. There's a variant called the Mu variant, MU, that has been reported in the media, something that we're watching closely. There is the potential for new variants to emerge that are going to be resistant to vaccines. Now, we all have our fingers crossed. We have not seen it yet. We've also seen in areas where some of these other strains have come and the Delta variant is prevalent, is that the Delta variant is so infectious and contagious that it overwhelms other variants. And the vaccines are effective against the Delta variant. And this is why we need to really get a handle on this now. We really need to all get vaccinated. We need to, stamp out this virus now so that new variants don't emerge. And the vaccines will also prevent and help, right? So variants emerge when there's ongoing replication and transmission in the community. So if we suppress that with vaccinations, we'll also help prevent the emergence of new variants.
And I'll just add to your point of the question, it's why it's so critical for us to get our vaccination rates as high as possible. It's not only for protection right now, but it will protect us as a society, as a state, from the future in whatever other kind of variants come, particularly if the vaccine is less effective of them in the future. If we have 95% of our population vaccinated, it puts us in a much better position to fight against those other future variants. And getting those rates up here in Rhode Island, we have a head start. We want these policies to help advance that, and all of you to help and do that, help us in doing that. We also know that it's critical throughout our entire country to help achieve that, because places where the vaccination rates are lower increase the risk of immune escape and new variants coming into place that are make the vaccine not as effective. But we can prevent that if we really push on what we're doing now. Thank you.
Representative Chippendale.
Thank you, Chairman. And thank you, everyone, for appearing today and for testifying. First, I would be remiss if I didn't thank Neil and the team for providing data when asked. He's been extremely helpful, as has the entire team, in providing data in what I know is a very hectic time in your world. So thank you for that. One of the things that I was particularly interested in and trying to just understand a little bit better to see if it matches what we are getting for anecdotal information, whether it's from folks in hospitals or medical staff or whatever, was the demographic breakdown. And I'm going to put you on the spot, Dr. Chan, because Neil said that you guys are doing some studies, particularly with Brown, more on that granular level where you're looking at these types of things. So when we consider the folks who are being hospitalized, that's one group, right? We have the contracted group, we have the hospitalized group, and we have, unfortunately, the death rate. And so those are the three areas that Neil has been providing me information on. What's not in there and what's not collected by health is, are we dealing with primarily folks who are morbidly obese, diabetes, immunocompromised? Are those the folks predominantly being hospitalized, of those being hospitalized? And are those, regrettably, the folks who are dying of those that are dying, and, you know, advanced age, all of those things that we know and we've come to accept are risk enhancers, if you will. Do you have, even if it's just a sort of roundabout estimate based on what you've been observing, do you have any way to articulate what that demographic breakdown is in hospitalizations and deaths?
Yeah, thank you. It's a great question. And I will say we have looked at this in depth, and it is exactly the populations that you state. So age is really the biggest risk factor for significant disease. So the older you are, for sure. And then, as you mentioned, obesity, being immunocompromised, and just having any other comorbid health condition really puts you at greater risk of dying from COVID. Not just getting COVID and having severe complications, but of course dying. It just complicates the whole picture.
So, and I think we kind of expected that, right, from the data that we had. So one of the things that I had mentioned, I think it was one of our first, and it was, of course, a Zoom task force meeting, that I just questioned. It was more or less a question, and I'm questioning it today. Why aren't we doing more to, in addition to beating the drum, quote, it works and it's safe, quote, we need to push the vaccine as much as we can. In addition to that, why aren't we just continuing to raise that awareness? Get off the couch, do some exercise, go outside, get vitamin D from the sun, stop smoking. We can be doing that at the same time as we're twisting people's arms about getting vaccinated, and I think that may provide a greater service to those folks who are most susceptible to hospitalization and death. That's an observation. I would love to hear whether or not you agree with that observation.
Absolutely. That's core to our public health work, and I can certainly say with confidence that our folks on the team at Rhode have been continuing that as full court press, that all of the preventative approaches, exercise, nutrition, wellness, work-life balance, vaccinations, all of these are key to prevention and making sure that people have access to the longest lives they can live. And our push is also making sure every community has the opportunity to do that as well, regardless of the zip code that they're from.
So when you say your push, certainly I see whether I'm listening to Spotify or I have the radio on or I have the TV on or I'll open up the newspaper, I'm seeing a very concerted effort to say, get vaccinated, wear your mask. Maybe I'm missing it. Where are we advertising and encouraging people to get healthy and stop doing the things that are making them more at risk for death?
It's happening in multiple ways, all part of just our public health approach. Right now, certainly the ones that are most prominent are the COVID-related ones, but we're still engaging with our providers. We're engaging with community-based organizations and having those conversations. We're supporting all kinds of activities that support it with diabetes, obesity, nutrition, working throughout the communities and really helping to assess at the community-based level what interventions are going to be most effective. And we'll, take that. I certainly haven't mentioned it to the same extent at a press conference, but it is something that is critical, and we can incorporate that into how we're continuing to get the message out.
I think that does make sense to do, and I think we could place a greater emphasis on that and perhaps invest a lot more messaging in that aspect.
Thank you, Representative Chippendale. Representative Place.
Thank you, Mr. Chairman. I've got two general areas of questioning. Do you want me to take them all at once, or do you want me to yield the floor back for other members before?
Let's do the one so we can get everybody in.
Okay, thank you.
And then we'll come back to you.
So, going back to Representative Messier's question, out of the hospitalizations, because I didn't hear an answer to her question. Her question was, out of those folks that are hospitalized, how many of those are vaccinated? How many of those are unvaccinated? So in my mind, that's a continuation of her question, because I don't think that question was actually answered. So do you know the actual numbers, the percentages in terms of hospitalizations and those that have been vaccinated, those that have not been vaccinated?
We absolutely have that data. This is just cases, it's not hospitalizations. But the key is knowing that it evolves over time. So prior to the Delta strain really accelerating in July, the majority of people who were hospitalized were unvaccinated. You may recall CNN had published in the middle of the summer, 99% of people who are hospitalized right now are unvaccinated. So that's a critical answer. With the Delta strain, because of its significant transmissibility, instead of one person infecting 1 to 2 people, one person can infect 6, 7, or 8 people. You see an increase in cases across the board, as well as hospitalizations.
I understand. I do. Trust me, I understand it.
But that
it was the simple
more
question that was asked.
among
I just,
To finish, please,
I understand.
Representative,
I understand how you come across. I understand where you're going with this. I understand all of it, and a lot of people do. But where people come into a situation, they start to doubt it's a simple question. We're just asking a simple question, and if you answer it and we go on with it, then we can move on with the hearing. But it's a simple question. I mean, out of the people that are hospitalized with or for COVID, what percentage have been vaccinated, what percentage haven't? You said 99% for CNN reported 99%. Well, Rhode Islanders would like to know, in Rhode Island, out of those that have been hospitalized, what number have been vaccinated, or percentage, whichever you prefer, have been vaccinated or have not been vaccinated?
Dr. Scott, some decorum here. Allow the person who is speaking to finish their chain of thought. We're not going to overtalk anyone in the room. You'll get your questions answered according to fashion. Please understand that. There are a lot of people who want their questions answered, and we owe it to them to finish their chain of thought prior to us butting in and ruining their chain of thought. So please understand that, Representative. Dr. Scott.
Yeah, thank you, Rep, and thank you, Chairman. Rep, in slide 36, it's not hospitalizations, but it's a slide in the appendix that has case rates by vaccination status. I know you're looking for hospitalizations. That's some of the data we've actually been working with Representative Chippendale to get, and I'm happy to forward it to you right after this. It's not in a percentage-wise, but we can make that happen pretty quickly.
And we have it. I just don't have it in front of me right now, and I'm telling you that with the Delta variant, we have an acceleration of people who are hospitalized. The majority of them are unvaccinated. That's the final answer. The majority of people who are hospitalized are unvaccinated.
Okay. Now, again, there's been some going back, continuing along with the hospitalizations, and then I'll yield my time back for other members. When we're talking about hospitalizations with COVID, COVID-related, or for COVID, can you differentiate between those numbers in terms of, if someone came into the hospital, they tested positive, so they're in the hospital positively tested for COVID, versus actually in the hospital because of COVID, i.e. they're symptomatic and the COVID itself is actually is the actual reason for the hospitalization, as opposed to we just found out that they have COVID because they were coming to the hospital for something else. Are we breaking that data out with this at all?
Yes, we are. And we have data that shows over 90% of the people who are hospitalized have it's because of COVID. The with COVID number is extremely small. That's someone unfortunately gets hit by a bus, is hospitalized with something related to that, and they're tested and they find out that they also have COVID, but that there was no reason for them to go into the hospital with it. The because of COVID is the majority, well over 90% are in the hospital. And hospitals, the systems, for them it doesn't matter, because regardless, once people are there with a COVID-associated illness, it costs, it takes up the resources, it requires infection control, all the same steps occur. So we don't get into the specifics because no matter what, the outcome is still the same, but well over 90% are in the hospital because of COVID. Anything you want to add?
Thank you, Representative. The question has been answered, and you have the data that you can supply to the representative. That is correct. Representative McAtee.
Thank you, Chairman, and thank you all for being here. It's great to see you again, in person. The questions I've been getting, and I hope I'm not repeating because I was out of the room for a little while, are about the booster. Obviously, you've mentioned that it's 65 and older and those who are compromised. One of the questions is, how many months after the second dose should people get vaccinated? And do they need to get the same brand of vaccination that they originally got? And where do they go to get it? So, and is it already implemented? I hear some people are saying they've already gotten them, but the majority of people who are just over 65, not compromised, really don't know where they go next. So if you could answer that, thanks.
Yeah, it's a great question. So there's good data now that giving that booster shot for certain people really does lead to a better immune response and more protection. So at the current time, what is recommended and authorized is that for people who are moderately or severely immunocompromised, is they should get that booster shot. For people that have had the Moderna or the Pfizer vaccine, they should get that booster shot, that third shot, about a month after their second shot. For the Johnson & Johnson vaccine, we're still not sure yet. We're still waiting for some guidance by the CDC, by the FDA, on how to deal with booster shots and people that got the Johnson & Johnson vaccine. And we're also waiting for people that are 65 and older, and potentially for healthcare workers, we're waiting to hear about official recommendations from booster shots there.
And it should be the same brand, is that what you said?
Should be the same brand at this time, yes.
All right, thank you very much. And is there any data on whether or not people get the same reaction as they did to the other shots? Is that to be expected?
There is some emerging data on that, and it is expected the exact same reactions. There's nothing else that's shown up. There's no other signals that have come up in terms of safety and getting booster shots. Same reactions that one may have gotten the first or the second shot.
And Where are they, did you say where they're giving them at this point, or aren't we doing that yet?
Yep, state sites, any sites where vaccines are being
Yes,
administered.
all of those
Yep,
places?
all those
Okay,
sites.
thank you.
Thank you, Representative McGaugh, and I'm going to ask you to limit, because we have Dr. Fine, and they'll be here after to answer other questions after we get Dr. Fine, but you have a question.
Yes, thank you. My question is around, it's sort of a two-parter, but I will try to keep it brief. But it's around people who get their vaccination out of state. There were reports in the district that I represent in Tiverton and Little Compton about low vaccination rates. And there was some question among the community about whether or not those numbers included if people got their vaccinations out of state, so if they crossed the line into Fall River and got a vaccination, or if they were in Florida and got their vaccination and flew back. So the first part of my question is, how does the Department of Health gather that information, and is all of that part of the numerics that we're working with? And the second part is, for those communities where the vaccination rates are lower than in other parts of the state, what is the Department of Health doing to help those communities increase their vaccination rates?
It took time early on in the response, but we've been able to get information from our neighboring states, such that if you see on the appendix slide 35, we are able to break down vaccination based on Rhode Islanders vaccinated anywhere, compared to all of the vaccinations administered within Rhode Island, to help be able to differentiate. So now, when we are reporting, it is taking into account if you've been vaccinated in a neighboring state, as long as you are a Rhode Islander. For what we are doing, there's an entire amazing team of people that are working diligently, community by community, to ensure that vaccination rates are addressed. We have our overall vaccination campaign that I shared of phase 4, which really focuses on policies and helping to make it a norm and part of the culture to get vaccinated for working in a healthcare setting or in a school setting. We're encouraging all businesses to require vaccination. Many people who were kind of on the fence say they then changed over to get vaccinated once it was, asked of them in their work setting. And those are the age groups, working age populations, where our vaccination rates have room for improvement. So that's how our policies are really focusing in on those approaches. We also have a massive program of pop-up clinics that are in place, doing assessments at the community level to see what locations work well, whether places of worship or community stores or other pharmacies, but really an all hands-on-deck approach that now has been expanded to include the policies of building on what we were doing with phase 3, which is meeting people where they are and working particularly in the areas with the lower vaccination rates on implementing whatever strategy worked tailored to that community to get those rates up. And a big part of it is this messaging. It's people, individuals talking to their loved ones, hearing this message, going ahead and getting vaccinated, and then talking to your loved one, talking to your coworker, talking to who you go to a place of worship with, and saying, it was fine, I did it, I'm actually more comfortable because I know now that my risk of being hospitalized or dying significantly decreases now that I've been vaccinated. Getting that message out is how we're going to get individual by individual to get our statewide rates up as high as we can go.
Thank you. Rep. Chippendale, before we move on.
Thank you, Thank you, Chairman. So one of the, in one of the slides, it was stated that if patient outcome is at risk, they will be forced to create a corrective action plan. That's what I think we were talking about within the various institutions. It was just coincidental when I was going through my mail on my desk today that I have a letter from the Rhode Island Partnership for Home Care, and they state fairly authoritatively that they're dealing with approximately a 1/3 drop in paraprofessionals in their field, and 10% fewer nurses. Now, that's certainly just one of the elements that you guys had listed, but I think we all recognize that there is, there has been some people leaving. Maybe they were close to retirement, maybe they're burnt out from the last 18 months, who could blame them? And then some are leaving because they just don't want to face the deadline and have to deal with it at that point. And I think we all recognize that that will bump a little bit once we get to the deadline. So as far as patient outcomes, I think we also all recognize that a lot of folks have, over the past 18 months, they've skipped their screenings for really preventable and treatable things such as colon cancer, breast cancer, mammographies, colonoscopies. Those things people aren't doing, and that's not anecdotal. That's been established that is happening right now. In manufacturing, we use the term pig through the snake. I think we're going to see that pig through the snake at some point. I don't know when. You guys are the doctors, not me. I'm just a dummy from Foster. But we're going to have a health crisis outside of this. That is, those folks who have put off, out of fear or whatever reason, getting those regular checkups, getting those screenings, doing the things that we really hammer into people's heads with, Colon Cancer Awareness Month and all of the things we do. And when I say we, I mean all of us. I do see a healthcare crisis. We all know folks who work in healthcare right now, and they're struggling. It's not just that the CNAs are leaving and that nurses are leaving. It's that the folks who make sure there are gauze pads on the shelves and that the oxygen is working and that the floors are clean and that the food gets delivered and that all of those folks, the supply chain folks, they're leaving because, frankly, they're not licensed professionals. They can go somewhere else. CNAs are leaving to go to McDonald's because McDonald's is paying $17 an hour. We can't compete with that. That's a reality that we're all dealing with, everybody, policymakers and you guys too. So I believe we are in a double health crisis right now, and I think it's only going to get worse. I don't like the idea of this get the vaccine or you're fired in healthcare. I know why you're doing it. I get it. I think we should consider natural immunity in part of that mix so that we don't realize a pig through the snake at some point, which is inevitable. But I know I'm not going to change your mind on that. Are we prepared for what is going to happen when it comes to a rash of otherwise preventable cancers and other illnesses? Are we prepared for that?
Yeah, so there were a few points that you made. One is the natural immunity piece. If that worked, it would certainly be something we would offer. We just have the data that shows natural immunity alone is not effective in what we're seeing with this Delta strain because of how transmissible it is, because of how rapidly the strain increased and became predominant based on the data that we showed. The majority of people who have had previous infections had a strain that was different from Delta strain, and so that natural immunity is not enough to protect against it in the way that the COVID vaccine could. And even still, the vaccine is necessary to help minimize reinfections, as we showed from the data. So that is why we did not, even though, understanding your desire to use if that worked, we would, but it wouldn't. What's helpful is that we are starting with, even in advance of October 1st, 87% of our healthcare workforce vaccinated, and the majority of healthcare employers saying they will be compliant by October 1st. So knowing that we are achieving that first part of our goal, which is to ensure the safest healthcare setting possible protected against COVID, is critical. We also are taking into account and very concerned about maintaining the second goal of sustaining high quality care across a stable healthcare system. And the point that you mentioned is a critical one that we have recognized because of staffing crises nationally. And because of just the fatigue and everything that is going on, what our healthcare systems are dealing with in being maxed is a situation that COVID is just one piece to it. We haven't even really begun the flu season yet. You know, there are other viruses. There's the behavioral health crises that are occurring. What we are doing is all the more reason why every one of the prevention strategies we've talked about is critical. Simply wearing a mask makes a difference in helping to protect our healthcare system capacity and to make sure that your loved ones can go in to get, you know, cancer treatment or some emergent surgery they have or whatever other care is critical that may not even have to do with COVID. We also know people have delayed their treatment and need to be able to access the hospital setting. So wearing a mask, taking advantage of our testing as often as possible, everybody getting vaccinated, making sure ventilation is set up in all of our businesses. We can all play our part in ensuring that we keep our healthcare system as protected and stabilized as possible by doing these very simple public health tools that will make a difference for COVID, for flu, for respiratory syncytial virus, for any of the other viruses that are there, and make it so that all of our loved ones who we want to be able to have the care, if they have a heart attack or something else, can get to the hospital and receive that care in a high quality format within a stabilized healthcare system. So those prevention strategies that you are pushing and that we're really saying have to be fully compliant with in our school communities and our businesses, vaccinations, testing, indoor masking, and ventilation. Remembering those four, applying them in your business settings, making sure parents are making sure it's working effectively in all their school settings. In any place that we go to, that's what's going to make a difference in ensuring that our healthcare systems are able to provide the high quality care for those that need it.
Thank you. Okay, at this time, in the interest of time, I'd like to bring up Dr. Fine. Could you stick around because my colleagues here still have some questions that may need to be answered? Or somebody from the staff?
Yep.
Just to answer the question.
Thank you, everyone.
Thank you.
Thank you, Dr. Chan. Appreciate it very much. Thank you. Thank you so much. Really appreciate it. I'll be in touch.
Welcome, Dr. Fine.
Really appreciate your commitment.
You now have the floor.
Thank you, Mr. Chair, and members of the committee. It's a great honor to be before you again today. Before I delve into my strong support for the Rhode Island Department of Health's very long-standing regulation and protocol for the testing of and vaccination of healthcare workers against a number of communicable infectious diseases, and try to put where we stand vis-a-vis COVID-19 in Rhode Island today, I want to take a moment to publicly honor my old colleagues in the Rhode
Excuse
Island
me,
Department
Dr.
of Health.
Chan? Dr. Chan? I mean, Dr. Fine. Could you move a little closer? We're having difficulty hearing you.
How's that?
A little better.
Any better? Do I have the right button up? I think I
Yeah,
must.
you have it up, but I think you're muffled because of the mask.
Okay, let me try to do a little better. So again, I want to take a moment to publicly honor my old colleagues from the Rhode Island Department of Health who have given their all for now almost 18 months without complaint or pause and have done a very great honor to their professions, to the noble cause of public health, and to the great state of Rhode Island. I also want to acknowledge in particular my colleague and friend, Dr. Beata Nelkin, who practices by herself on Broad Street in Central Falls, and who's worked tirelessly throughout the pandemic with no direct public support, caring for the kids of Central Falls and their families by herself. She's immunized about 5,000 people in Central Falls, many of whom are undocumented, and have no other place to go for medical care. By herself, she and her staff test over 100 people a day, and she provides pediatric care to 15 to 20 kids a day. She pays for much of the testing she does out of her own pocket, and she often doesn't charge people who are undocumented and uninsured. She's a true Rhode Island hero, and I thought you would want to know about her work. I first want to offer my strong support for the Department of Health's long-established responsibility to protect the health and safety of Rhode Islanders by preventing the spread of infectious diseases. For over 100 years, we've prevented that spread by a number of measures, by vaccination, testing, contact tracing, isolation, quarantine, spraying for mosquitoes, and frequent but strategic public health communications. Sometimes we have to close a classroom or a school for a few weeks. Sometimes it's a business or a beach. These processes, which take painstaking detective work and sometimes painful enforcement, have been amazingly effective. We've stopped TB, though we get a few imported cases every year. No one remembers the last human case of rabies. Rabies is an incurable disease that remains endemic among wild animals in Rhode Island. We never got Ebola, which kills 50 to 75% of the people who get it. No physician I know has ever seen a case of measles, which used to kill 500 children a year in the United States, the same number of children who have died as a result from COVID-19. None of us have ever seen diphtheria, which used to kill 15,000 kids each year in the United States when the population of the country was 100 million less. Diphtheria has a case fatality rate of between 10 and 20%. That's right, diphtheria used to kill 20% of the kids under 5 who got it. I've never seen or even heard of a case because of good public health. The testing and immunization of healthcare workers for TB, hepatitis, measles, mumps, diphtheria, pertussis, tetanus, varicella, influenza, and now COVID-19 has been part of the routine requirement for the licensure and regulation of healthcare workers for as long as any of us can remember. The specific regulations have changed over the years, but the role and responsibility of the Rhode Island Department of Health in protecting the public, that's been there as long as the department has been there, and it is integral, it seems to me, to the maintenance of a free society. Every state in the union requires vaccination on school entry. Many states have vaccine protocols for healthcare working, testing, and immunization, as you've heard, often tied to licensure, but they don't all require the same test or vaccination. As of August 20th, 24 states had healthcare worker vaccination requirements for COVID-19. But even more important than these protocols is the ethical basis of our healthcare professions. Our job is unself-interested advocacy. It is core to the integrity of the health professions that health professionals put their patients before themselves. You and the public need to trust health professionals to protect them. When I get vaccinated, I'm not focused on the risk for me. I'm focused only on the risk to you if I'm not vaccinated. And that's exactly the way it should be. Now let me talk for a few minutes about COVID-19, where we are, how we got here, and perhaps a little about what we need to do to beat this thing into the ground once and for all. As everyone knows, COVID-19 is the disease caused by a virus called SARS-CoV-2, a new virus to human beings that crossed over to us sometime in 2019, very likely in China, and then spread around the world, evolving as it spread. It's difficult and a little more dangerous than it might otherwise be because it's new to us. And until about 2 years ago, no one was immune to it, which means we're all likely to get it eventually. The good news is that it isn't a very dangerous infectious disease as infectious diseases go. It killed about 6 of every 1,000 people who got it at first, and now kills about 2 of every 1,000, about twice the rate of flu. The bad news is that it has become exceptionally infectious, and it preys on the old and the sick, as you heard, killing as many as 10% of people over 80 who are hospitalized with it. And the bad news is that it will kill some younger people and some kids, numbers that become meaningful when you realize that many more kids and young adults, there are many more kids and young adults than there are elders. But it is also true that there's lots we don't know about COVID-19 and its population dynamics. We're learning every day. That's part of why you've heard so much confusing information in the beginning and why it is so terribly important that we be clear about what we know, what we don't know, and that we be as honest as we can about what is just a guess or a projection so that people know where they and we stand. As we discuss the numbers, I want you to understand that I think there are three numbers that are most important: hospitalization rate, COVID mortality rate, and the community transmission rate. That said, please understand that the mortality rate, which I'm going to spend the most time on, is as of this week. When we compare countries and states, where we are today isn't as important as where we are at the end of the pandemic. There are surges and seasonal variations. One country might look great today, but it might fall apart in 6 months with a new variant or because of some change in behavior or a failure to vaccinate. That said, some countries have done 20 times better than the US, which means that if we had done as well as them, we'd be mourning 35,000 Americans this week, not 700,000, which is where we are today. I'm not actually going to talk about the community transmission rate number in much detail, although I think community transmission is of utmost importance and hasn't attracted the kind of focus it needs. Community transmission means how many people now have COVID-19 in Rhode Island and how fast it's spreading, remembering that each person who has the Delta variant is thought to infect as many as 8 other people. And some of us believe, and this is a projection that you saw based in Dr. Chan's presentation, somewhere between 10 and 20,000 Rhode Islanders are walking around with COVID-19 today. I'm not going to talk about our actual community transmission number much because it depends too much on how much testing we are or aren't doing and who we're testing. But please understand that the community transmission predicts hospitalizations and deaths with a 2 to 4 week lag. At our level of community transmission, we're seeing and should expect to see 1 to 4 deaths from COVID-19 a day. And that number of deaths will likely stay the same until the level of community transmission goes down, or perhaps until a much larger number of people are vaccinated. Please understand that when we encourage more movement and more interaction at this level of community transmission, we're accepting the number of hospitalizations and deaths we have now. For a number of technical reasons, the vaccine alone won't make hospitalizations and deaths go away just by itself. We have to do a bunch of other things to get that done. But if we do those things and reduce community transmission to a low level, likely 2 to 5 new cases per 100,000 per day or 15 to 35 new cases per 100,000 per week, that's 20 to 50 new cases per day in Rhode Island as a whole. That by itself would be associated with few hospitalizations and many fewer deaths, which is what we had for a few weeks in July of both 2020 and 2021. This rate of community transmission is just not, it's not just a number. It tells us how likely it is people who are vulnerable, how likely it is that they are to get this disease. And when the vulnerable people get it, the vulnerable people end up in the hospital and they are much more likely to die. So, the United States has the 21st highest death rate in the world at about 2,084 deaths per million population, or 1 death for every 500 people. We've lost about 700,000 Americans to COVID-19 and are now losing over 2,000 people a day in the United States, but that number is likely to shrink some as new positive cases were falling around the country, though there's some data today that suggests maybe they're upticking again a little bit. For my money, the U.S. COVID-19 response has been a dismal failure, a result of the extent of our political division and the extent to which we've allowed our politics and our obsession with commerce to intrude on the public health process. From where we stand today, many other nations, over 150 other nations, in fact, have done better than us, and some way better. Nations, some of which are large, diverse, and developed nations like South Korea and Japan, which have accurate reporting, where they're seeing deaths per million in the range of 50 to 150, not over 2,000, 1/10 of ours, 1/10 to 1/20 of ours. If our response was like theirs, we'd have 30 to 60,000 dead instead of almost 700,000. In Rhode Island, that means we'd have 140 to 180 dead, not over 2,800. Singapore has 10 deaths per million. Australia is at 46 deaths per million. All this could change tomorrow, but probably won't. They've done well during the whole pandemic and are getting their people vaccinated. The US put a man on the moon. We stopped Hitler. We developed this vaccine. Surely we can and must do better as a nation. Rhode Island started the pandemic with much greater than average risk of rapid disease spread. We have lots of old people, 31,401 over 85 at the start of the pandemic, according to the 2020 census. We're 9th in the nation for people over 85 and 13th for people over 65, with more than 11% of our population over 65 living in poverty. That's important because people over 85 are at the highest risk of death from the virus should they contract it. We've lost 3 to 5% of the Rhode Island population over 80 to COVID, over 1,600 of our 2,800 deaths. And the Israeli data suggests that people over 85 and those with chronic disease who are vaccinated and get COVID have the same chance of hospitalization and death as people who are unvaccinated, which is why reducing community transmission is so vitally important. It's the only way we really have to protect our elders other than really cocooning them, making sure they stay home, which is something we really haven't been great at doing. We're also at greater than average risk because we're so densely populated. We're second in the nation in terms of population density, though we're not as densely populated as we once were compared to other places. Central Falls is the 27th most densely populated incorporated place in the United States. Parts of Pawtucket and Providence are also very densely populated. Population density is important because of the way infectious disease spreads, because infectious disease always spreads in densely populated places. Public health as we know it started in Europe in the 1820s and 50s after the outbreaks of cholera in densely populated places. We're also at risk because we have too many people living in poverty. We're the 32nd poorest state in the nation, second poorest in New England. That's important because people living in poverty have to go out of their houses to work every day and often work in close proximity to one another, providing an opportunity for the disease to spread. People living in poverty can rarely work from home. There are factory workers, our store clerks, our fast food workers, our CNAs, and our landscapers, and often our construction workers as well. The unacceptable overlap of race and poverty is well known. Too many people of color live in poverty in densely populated housing and suffer multiple risks of COVID-19. Another risk, Rhode Island is one of 6 states with no local health departments. Only about 50% of us have and use a primary care physician. We're 12th in the nation for the number of people who speak speak languages other than English at home, which makes public health communication more challenging. All that said, here's how we've done so far as a state. We're 8th in the nation for deaths per million, with 2,815 deaths as of yesterday, 46 in September alone, so we'll likely have 60 to 75 deaths in September and a similar number in October and perhaps November, because our level of community transmission remains high and does not, from what I see, appear to be decreasing, and is unlikely to drop given school has just started and that people will be moving indoors in the next month. We may also see more deaths because vaccine immunity, which most of us think lasts about 6 months, is likely to be less than it was until people over 65 get boosters. Our mortality rate is 2,657 deaths per million. If we were a country, we'd rank 10th in the world for mortality by ourselves. We've had about 11,000 COVID hospitalizations in Rhode Island since the start of the pandemic. Our current 14-day hospitalization rate is 24 per 100,000 people, an 8% increase in the last 2 weeks, which is troubling. And we're in a four-way tie for 25th in the nation, mostly because the unvaccinated states are experiencing very intense surges. There is good data. Oh, I'm sorry, I don't have good data that compares our cumulative hospitalization rate to that of other states. There is good data, however, on child hospitalization rates, which have climbed by about 10% over the last 2 weeks nationally. We've had 286 children hospitalized in Rhode Island. Our child hospitalization rate has remained stable through the last 2 weeks, which is great given the jump up in the national rate. But data from Israel and the UK tell us that that rate should have dropped by 2/3 given our vaccination rate, which tells us just how infectious the Delta variant is. We're 7th in the nation for the number of cases, but I don't put too much store in that number because we've done more testing than most other places in the US, but not nearly enough from my perspective. You do more testing, you find more cases. Our ranking has improved somewhat in the last month, but that's not because we're doing better. It's because other states which have lagged in vaccination have caught up and passed us in terms of number of cases. We're the 5th most vaccinated state in the US, something to be pretty proud of. And as you've heard, we're about 67% vaccinated, which is a very good thing. But we're used to being the best vaccinated state in the union, in part because of your support of the Rhode Island Universal Vaccine Purchase Program, which buys vaccine for every Rhode Islander and has stabilized vaccine supply for the last 20 years. The good news is that we may be able to start vaccinating children 5 to 12 soon, and I think the vaccination of kids will help us end this pandemic by the end of next spring, but likely not before. The bad news is that the contagiousness of the Delta variant means we will likely need to get 90 to 95 vaccinated before we can reliably bring the pandemic under control. The other bad news is that about 140,000 vaccine-eligible Rhode Islanders remain unvaccinated, with 52% of Black Rhode Islanders and 48% of Latinx Rhode Islanders unvaccinated. So the pandemic is likely to continue to prey most on people of color. Can we do better? I believe we can, but doing better involves a much deeper commitment to public health and a change in our priorities, so we stop trading off lives for commerce. We need 10 times the number of public health workers that we now have. We need to involve our primary care practices much more deeply in this effort. We can support our businesses through this economically, but we can't get back the lives we lost and are losing every single day. I'm way out of time. I'm happy to answer questions about what we have to do to improve our performance in the Q&A. Thank you again for this opportunity, for your interest, and for your commitment to protecting the health and safety of all Rhode Islanders.
Thank you, Dr. Fine. At this point, I'm going to ask you to come forward and state your name for the record.
Thank you, Chairman. Neil Heitman from the Rhode Island Department of Health.
Okay, we will now open up for questions. Representative Place.
So I was listening to Dr. Fine's comments. I'm not sure that my question may have been in your comments, but it was trailing off a little bit as you mentioned it. One of the focuses of initial phase 1 and phase 2 vaccination were underserved communities within the state's specific zip codes. And this is for both. I don't know who best answer the question. And I'm just curious, do we have the vaccination rates for those zip codes that were initially targeted? And do we have the vaccination rates by community throughout the state so that, you know, we can see which communities, not only demographically, but actually geographically, are, you know, most hesitant when it comes to the vaccine?
Yes, absolutely. Rep, on our website, our Rhode Island Department of Health, we do have that breakdown by municipality, and we also have separate demographic breakdowns. If you're interested in looking at demographic breakdowns by municipality, that's something we can work towards. But the overall picture, you know, overall vaccination rates are there on our website, and I'm happy to send that to you.
Could you get it in a timely fashion since he's asking for it?
Absolutely.
All right, any other questions? Representative McGaugh?
I have a question about the timeline of the new Biden vaccination plan, or I'm sorry, COVID mitigation plan, and how that interacts with what we're doing here in Rhode Island. I haven't really seen a timeline for the national vaccine plan, for example. So there's a vaccination program for healthcare workers that's happening nationally, but I haven't seen a timeline. And I'm just wondering if you can put into context what it is that we're doing here in Rhode Island in comparison with what's happening with the national plan.
Sure. Feel free to jump in, Dr. Fine. But I don't have, like you, I haven't seen any specific timelines be announced in regards to the president's initiative to get companies larger than 100 vaccinated and some of the other announcements that's been made. But we're absolutely working and think we're in a good spot with our overall vaccination rates to meet some of those goals. But we have not yet heard any deadlines, but happy to update you when we look into it further.
The approval of boosters is a rolling process, and it's been before FDA. I don't think it's finished through ACIP, which is part of CDC. So I think we will have to wait and hear over the next week or two what the final decision is and then what the timeline looks like for boosters for people over 65 as opposed to boosters for people who are immunosuppressed. We are able to do boosting for people who are immunosuppressed now, but we haven't been authorized to go ahead with people over 65 yet. That, as you understand it?
Yeah.
Any other questions? Yes, you may.
Sorry, I have one more question. I promise this is my last one. But I'm just wondering, there's a lot of myths and misinformation out there about vaccination programs and about the vaccine itself. And what I'm wondering is, the Department of Health doing anything to dispel those myths? Is there a social media campaign? Are there going to be PSAs that specifically address some of the misinformation about the vaccine so that people who right now are vaccine hesitant can obtain the narrative about the information that's important to help bring them around to encourage them to get vaccinated?
I'll start, and I'm not a doctor, so I'm happy to let a doctor jump in. But from the Rhode Island Department of Health's perspective, yes, it's a consistent and constant battle working with our communications team to combat a lot of the misinformation that's spread. on the internet and in certain anti-vax circles. It's important for us to always put forward the most accurate peer-reviewed medical information and literature and make it as easily accessible to the population widely. We have been working with specific community groups through our HES infrastructure, through different through different community groups, including our unions, to reach those to hear really what those communities are hearing as what's the myths that are preventing folks from getting vaccine. Some of the common trends I'm sure you've all heard are some of the concerns regarding fertility in certain populations. There's no evidence that the COVID vaccine has any adverse impact on fertility. There's a lot of evidence that having COVID can harm fertility. So it's really meeting people one-on-one as much as we can, and it is there's a lot of it's really hard. It's one-on-one conversations, and I want to thank you all for helping disseminate that accurate information that we have, that we and the CDC have. And if you get some of those concerns and you can't answer them or you can't find the information, please send them our way, and we'll work with you to clear them up.
If I may, Doctor, we need to hear from you because you're the only doctor in the room right now.
Now I'm in trouble.
And no disrespect at all, but we need to hear from you since other people are listening, and we rely on the data, but we also rely on your education and your knowledge. And no disrespect, please, when I say that, but he's the only doctor in the room. Could you elaborate on her question a little bit more so that people feel comfortable?
This is really hard, exactly as Neil said, because the myths and stories and beliefs vary from community to community. The beliefs in Foster and Gloucester are pretty different than the beliefs in Central Falls and in Pawtucket and in Providence. The beliefs in the Dominican community are different from the beliefs in the Cape Verdean community. We have the advantage of living in this amazing state of different communities, but that makes public health communications way harder. I'm an old guy, and I remember when we had 3 networks and everybody watched the same thing. Now everybody watches their own stuff, and there isn't a good way to do public communications effectively. It's one-on-one. But here's something that I think we've missed, and I've been pretty vocal about this. I don't think we've used and taken advantage of our primary care community adequately. People trust their doctors, and it is really important for us to activate their doctors and nurse practitioners and PAs, their primary care practices, not just to wait till people come and ask, but to go person to person and reach out to every person, listen to what they think and feel, respect what they think and feel, and answer their questions. And I think it's been shown to be a hugely important way to move this forward. I don't know if you're familiar with a poster named Frank Luntz, but he's done amazing work around the country, and particularly in the last year, where he's been really trying to figure out how to get this done. And he doesn't come from a political perspective that traditionally supports this kind of communication. But Frank believes that the work of primary care clinicians and doctors and nurses is really important. And man, I think we ought to do 10 times as much, reaching out to them, involving them, activating them, and so forth. We basically went around them early in the vaccine campaign. That's something that I was sorry about, and I think we could do way better in that regard.
Representative Chippendale.
Thank you, Chairman. Rep, I had just searched on just a plain Google browser, COVID myths, and DOH's website was, I think, one of the first, if not the first, and it has a whole entire section on the myths. It was exactly, I think, what you were asking. It was very comprehensive. So that does exist, certainly out there. I can't agree more with Dr. Fine relative to the underusage of the PCPs. They've essentially been sidelined. They're taking blood pressures and taking temperatures right now. That's it. I think that's a really big missed opportunity. And then I'm just going to finally, I'm going to share what I believe, what I see as the hesitancy. Again, as the doctor pointed out, it's different from community to community. So folks with whom I speak about this issue and their hesitancy to get the vaccine largely goes back to the beginning of the whole thing, where, you know, don't wear a mask. You don't need a mask. Healthcare workers, they need masks. Masks are doing nothing. Okay, all right, you got to wear a mask. Absolutely have to have. In fact, you have to have 2 masks. Like that was how it started with the masks. And vaccines are coming. Okay, they're coming. They're being rushed, but they're coming. They'll be safe. And then, all right, you're vaccinated, you're good. But it turns out you're going to need boosters. And also you can still get it, and yep, you can still transmit it. So it'll lessen your symptoms. Like, this is what people are consuming on a daily basis because, again, as you pointed out, it changes every day. That is what's breeding the hesitancy in my world.
And if I may agree and emphasize, not only is the switching communications breeding the hesitancy, but I think what we've done as a society over the last 20 years, which is introduce the business of medicine into people's personal medical care, has made it so that everybody's suspicious that somebody's trying to make money on their back. And so nobody believes anybody anymore because of the profit motive. It goes back to what I talked about earlier, the critical importance of us asking our health professionals to focus on their ethical commitment to patient care, on this notion of unself-advocacy, on always putting patient care first. We've got a long way to go to change that, and we've got to do some real hard soul-searching about what we've done to create this marketplace where we ought to have a healthcare system taking care of all Rhode Islanders.
Yeah, I mean, that's certainly a whole other area we could spend weeks and days and hours talking about, and I don't disagree again on that. But I did want to just get it out there that what my observations are, and I don't think that's going away anytime soon because things are going to continue to change. We are where we are. I don't know if it's going to get any better. Thank you.
Thank you. Representative Place.
So Neil, I went on to it, like you asked, took a look at it, and just some points. From a mobile perspective, I think the majority of us now are mobile users. You really can't, it actually doesn't pop up. Like it's not mobile friendly at all. So it's feedback to you. But what I draw from it is when you look at the percentages in terms of by racial demographic, the way you guys presented it, there's a large bar for white and then exceptionally small bars for both Hispanic and African American and all the others, comparable to what I believe Dr. Fine was saying in his testimony. And I went back and I also looked at the percentages for different municipalities. And I see that, you know, one of the municipalities I represent is around 58, less than 60%. Very comparable to, say, Newport. And then you get Tiverton, Little Compton. It's funny, and you know, some of the more urban areas are higher than those. And one of the reasons why I've been so vocal on this issue in terms of the vaccine mandates, stuff like that, because I know within my district that regardless of hesitancy or non-hesitancy, mandates or non-mandates, I know that the residents of my district are going to be disproportionately impacted by these mandates just based on the numbers. So again, you know, because of that, it's one of the reasons why I've been so vocal on these things. And how do we not look at this and see that these mandates are only going to have a disproportional impact on just Burrillville or just Tiverton, but even on these areas in which we tried so hard to avoid? I mean, our first round was specifically targeting specific racial demographics. And just based on what I'm seeing, it shows that we failed at that. But now we're going to mandate it. So folks are going to lose their jobs. It's folks from my district, and then folks from Central Falls, Providence, Newport, you know, they're going to lose their jobs over this. And I understand that there's public health concerns, but the desperate impacts on certain communities is just blatant to me. And I just haven't heard anybody talk about that yet. So I don't know if someone wants to touch on that. Neil, I know you're just the data guy. You're not necessarily the policy guy. But, you know, Dr. Fine, if you want to touch on that, I'd welcome your comments.
Dr. Fine, please, Neil, speak to that first. And
Sure,
then Dr.
sure.
Fine.
Thank you, and I thank you for the compliment that I'm a data guy. I am not a data guy at all. I have a great team of data people behind me. I'm just a public relations guy that's happy to help out. But to your point about targeting the disproportionate effects that we saw early on in the pandemic, that was a really big focus for us, to focus on where we saw a very disparate population of hospitalizations, deaths, related to COVID. That's why we started with our limited supply in those areas. Going out further, completely agree with you. We need to do more to make access to the vaccine more accessible in all the communities that you're seeing, that you mentioned, Little Compton, Foster, Gloucester, because ease of access is also going, you know, once you get somebody over the hump of vaccine hesitancy, making it easily accessible, continuing to make access free is going to be just as important. So there's kind of a twofold battle we have there. We're focused really hard on both of them, and would be happy to partner with you on anything you think would be beneficial to reach those in Burrillville.
Well, I would say just about anything but a mandate, because I know, speaking for my communities, government mandates don't tend to build trust. And that's something I've been saying from day one. I mean, I've had legislation heard, you know, dealing with mandates and vaccination cards and things like that. And one of the things I tried to do for your director was, quite frankly, set her up for softball questions. In my mind, they're softball questions. There are common questions that are being asked in the community that I think can be directly answered and explained, but they weren't. And my frustration obviously showed in the fact that these very direct, simple questions were asked, but not directly answered. And folks in these communities, whether it be Newport, Tiverton, Burrillville, Central Falls, they're not unintelligent people. They can understand the reasons behind things. They can also see when someone is giving a BS answer. I mean, I think some of these communities have some of the highest BS meters in the state. I mean, whether it just be mine or be Central Falls or wherever it is, I think some of these everyday hardworking people have the highest BS meters on, off the record. And unfortunately, this is my feedback. Stop BSing on certain things. Trust us to understand the real answers. Some of the answers I ask, I already have background information for. They're easily accessible. They're known. It's a simple question. And if you beat around the bush, people are going to be hesitant. They're going to cause the hesitancy. So you want my answer, Neil, in terms of how do I think you need to build the trust in these communities. And you build these trusts by being direct and honest with them. Don't BS them. And that's what I got. That's what I got as to the answers, because again, my colleague down here asked a very direct question, and it wasn't answered. And I had to then take up my time for my constituents to follow up and try to pull that information out. And it should be known. These are questions, you want to know? These are questions that are being asked. I'm asking these questions because people who are hesitant are asking these questions. People who have taken the vaccine are asking these questions. And they want these answers just to relax them. But if you BS them, it doesn't relax them, it doesn't build trust.
Yep.
So just be direct and honest. So you asked ideas, that would be my idea. When someone makes a presentation and a question is asked, be direct and be honest. Trust that we understand the reasons. So answer the question, then give us a reason. If you start to give us a reason but never answer the question, again, the BS meters go off. So There's my answer to your question, Neil.
No,
Thank you.
thank you, Rep. And
Representative,
can I respond?
Representative, and to the committee here, we're not in the business of setting anybody up. We are in the business to give information to our constituents. I hear your frustrations, and we all have them throughout the state. We're in the business to give information to our constituents. I will now ask Dr. Fine to answer the question.
All right,
If
I'm
you
going to have to steer my way around because I
Right.
think there were a couple of questions in there. In terms of how we deal with people who are upset about what they perceive to be a mandate and what I call routine public health process that we've been doing for 100 years, first, I explained that. Second, I think we might want to think about offering them some retraining or employment placement options, not disrespecting their opinion, but recognizing the difficulty that they and we are both in this time while we've got this disease and a fair amount of differing opinions about vaccination itself. And last but not least, I don't know if it's helpful, but the Israeli data suggests that between 16 and 20% of people in the hospital will be breakthrough cases. I don't know what the Rhode Island data is, but to get to your question, that's the Israeli data.
Thank you, Representative McGaw.
Thank you. Just for the record, can you identify any vaccinations that would be required for these healthcare workers for which we are now requiring this COVID vaccination? Can you identify any other vaccination requirements that might have been in place for them to obtain employment?
In fact, I can. And I'm an amateur now, remember? I'm not doing this full time anymore. But hepatitis B vaccination is required. MMR is required. DPT is required. Varicella is required. I'm probably TB testing is required. Remember, when we do the public health process, it's not all vaccination. It's a bunch of different things. It's vaccination, it's testing, it's follow-up, it's quarantine, it's contact tracing. There are a bunch of different pieces. So there are a bunch of different things we do for different diseases based on the disease and people's relative risk, but everybody's got those basic requirements as far as I know. You may correct me if you believe me to be wrong because you're in the middle of it and I'm not.
No, thank you. You covered the requirements. So.
Okay, I want to thank my distinguished colleagues for coming out today. Thank the people who are watching us today. I hope we were informative. We will meet again. I don't have an exact time, but please understand we're in this all together, and we will get to the end of this. And I thank you all for coming, and thank the people who are watching this evening. I make a motion to adjourn. It's been moved and seconded. Thank you, everyone.
Thank you, Chairman.